Good morning, respected Chancellor, Dr. Rajagopal, SMD, College, Dr. Dhanasekaran and other dignitaries on the dais.
என்ன வயசு இருக்கும் உங்க கிளாஸ்
Next batch.
Dr.C.K. what to say and what to leave, because my association is for so many decades. Only thing is I can say, both of us had the first batch of being the first batch of dental wing Madras Medical College, BD student. And his surgery teacher was Evan Gopal. And I being the last batch of this general surgery teacher is Dr. Evan Gopal. Then he was a honorary professor of general surgery in Government General Hospital, and he became a director of urology. So with my batch, that was the last batch till the first. CKD used to say that Dr. Evan Gopal is an inspiring person for taking up a surgery, and same thing with me also. And of course, CKD was my mentor, and I took my work, rather, I was a oral surgeon. Of course, on my own, I developed as a maxillofacial surgeon. He used to, one thing is, we used to amaze, I mean, he's such a teacher, great teacher. Only thing is, I never had the opportunity to work. I used to tell him, I never used to have the opportunity of working with him because he was my undergraduate as well as a postgraduate teacher. And as far as post-graduation is concerned, he was only for 1.5 years. No, he didn't complete. Before that, he left for Libya and never returned to government service, which is a loss to the Tamil Nadu government. That's what I used to say. And he used to say that he had that confidence about his, he used to narrate many stories, many things he used to share with me, because though I was not working with him, still I used to visit him in his clinic, and every time when I go to his clinic, he'll be having a book, reading a book, and so many times he will question me. Even after becoming a professor, he will make me humble that I'm not in a position to answer his queries. Then he will say, then he will teach. So I was a student till till he was there. Every time I go to his clinic, I will learn something from him, some tips or other from the surgical point of view. And he used to say, he used to narrate his student period. His teacher was Jinwala in Naya Dental College. He belongs to the second batch of Naya Dental College, MBA student, I think. And he used to say, he was such a bold surgeon. He used to say that you should be prepared to do cases under local anesthesia on a dental chair, doing an ankylosis or even a maxillectomy. And others, I still remember what word he told me. CKD was telling his teacher, it seems, sir, in the middle of the surgery, the patient will pop up from the dental chair and leave you. When you are doing under local anesthesia and ankylosis case, he will, Jinwala used to say that you push him back and do it, man. And I have seen it many a times. You know pretty well that a blind intubation is a problem for the anesthetist. And nowadays, and especially in government hospital, those days, the techniques were not there, intubation facilities were not that good. So they used to have a problem with, especially in children. And he used to take up the case initially, opening up the job in just few minutes. He will request the anesthetist, I'll do it and release the joint within few minutes. With local anesthesia, just little sedation is enough. And after that, you can intubate the patient. Seeing him doing that gave me confidence. And for my experience, as far as my dental college experience is very few. My experience is mostly in the rural area. Even in a taluk level, I started after my post-graduation. That gave me a confidence. Whenever there was a problem, I used to start opening the jaw with the local anesthesia. And then once the jaw is open, I used to, the anesthetist used to intubate and then do a good job. Thorough job will be done after that. But the initial release can be done under local anesthesia, especially children. It's very easy. And I'm a person, my teacher as well as myself used to do only under chisel and mallet or osteotomy and mallet, not a burr. We never used to. And people used to say, how come you people are doing it? All. And the one thing I want to tell you is the profession MDS program, the infections and all is done under birth technique only. Yeah, I don't say. But only chisel has to be taken, done under GA. But for a student's training, it is the chisel technique that only gives confidence in using a chisel and a mallet. That training we had those days, and that only gave us a confidence because I have seen many people, especially present day youngsters, taking up a chisel and doing certain part. They are not having any confidence at all. But there are certain areas where you should be having a skill to do only with chisel and mallet. Those type of trainings we had a thing, and CKD was such a great surgeon. Only thing is the knowledge I could gain only after visiting him in his clinic. I never had the opportunity of continuing. But occasionally he used to call me for assisting him when his assistants were not there before Murugesan was there, came when Uma Maheshwari was his assistant and all, when Uma is not there and all, one or two times I have gone for assisting also. That was the association I had. And one thing is this oration, the right choice is S.M. Balaji, because he also used to tell me, and I also of the opinion that though CKD was the first maxillofacial surgeon of South India, we have not taken it to the public. It is S.M. Balaji who has taken it. And because of him only, every time, whenever I do something or any cosmetic surgery or anything, sir, S.M. Balaji, they used to say. That name he has brought it, he has popularized, and as even among the doctors also, among the doctors, a few colleagues who work with me, like that CKD, along with CKD, people working with him, they were knowing. But it is S.M. Balaji who has brought the thing. And my teacher also of the same opinion, because I used to, one thing, the Guru Sishya will be there. But as far as I am concerned with the CKD, I used to be very bold because I never used to have any fear. But respect is there. Respect I never. But I used to freely talk with him. I used to question. Even sometimes his decision also I used to talk. And I'm questioning boldly as a postgraduate student, why you are doing this, why not you do the other way around. But he will not get angry. Only thing is he will look down on this who is reading glass, and then he'll say, whatever you say, I will do this way only. And you tell me, come and tell me tomorrow why I did this. Such type of thing I used to have. And still I remember him. And we missed him as a teacher. And of course, it was a great loss that he left. And see, it's like balancing only. The government has lost, government institution lost the opportunity, which Saveetha has gained it. And you see the institution, how it has come up with a dynamic relationship with Dr. N.M. Veerayan. Thank you very much. I think Balaji's experience, you will all be learn a lot. Thank you very much. Thank you very much for this opportunity.
Thank you so much, sir. Now, I would like to introduce our guest of honor, Dr. S.M. Balaji, sir. He's an internationally renowned oral and maxillary surgeon with over 28 years of experience and 20,000 plus surgeries. He is a global authority in cleft lip and palate surgery, having introduced innovative techniques widely adopted worldwide, and has rehabilitated over 1,000 syndromic children through complex reconstructive procedures. He served as the editor-in-chief of the Annals of Maxillofacial Surgery and executive editor of the Indian Journal of Dental Research, and is the author of the country's best-selling textbook of oral and maxillofacial surgery. Now, I would like to invite Dr. S.M. Balaji sir, please to deliver oration lecture. Thank you, sir.
Thank you very much. I see most of the senior surgeons, especially the batchmates of Dr. N.M. Veera. He's giving an alumni meeting now. It's like the old students meeting. So now I must thank, first of all, my lecture topic is on facial asymmetry, how you achieve perfection. I believe in perfection. You know, I have seen all the TM joint cases when you release the joint, they put a graft, they do it. Still the patients, when you ask the patient to open the mouth, like that, the jaw will go to another side. But you see my patient, they will open the mouth straight. You know, well, so before, that is my, you know, we are all here, nice air-conditioned hall. Who has provided this? Dr. Veerayan, he's a dentist from Europe, came all the way from Europe here to start the dental college. Can you believe? Can you start a dental college? Can any of the dentists start a dental college right now? He's not a MLA. He's not a MP. He's not a minister. He's not BCA president. He's not a vice chancellor. From a very hard-earned money to teach you all surgery, he started. You know, not only that, you know, he was 19. He studied BDS in the government dental college, mind you. He was selected on merit by the government of Tamil Nadu for BDS. He did his BDS, did his wonderful practice in Europe. Europe is a very potent place for private practice. I tell you, when I was in 91, I used to go there and operate from morning till evening. I was a lecturer there in JK College. I go to Europe in a private room. 5 clinics I attend. I do impaction, cyst enucleation, make little money and come back. So Europe is a very potent place for practice. And another thing, most of the colleges, I tell you, that there are many principles they would have worked. But, sir, your Honorable Dr.C.K. sir, something great. Because most of the principals would have fought with the management and left. But here, sir, this person, I know him from 19, you know, when I was a student in 1980, we all talked about, hey, this is a complicated case, send it to CKD. That was the name. But you have chosen the right person as the dean of your college, sir. He brought big name to the college as an oral surgeon. Then you picked up and you made it that all the 9 subjects of dentistry today, #1 in the world is Saveetha Dental College. Give him a big hand. You must all know what he has done in this college. And Dr. Veerayan has done something big for all of us. What people say, Madam said, I don't know how she's my wife is a Malayalam. She speaks Malayalam. I don't know my wife, she speaks good Tamil now. I don't know whether you can speak Tamil or not. I don't know how you learn Tamil from what I spoke in here. You know, nowadays I don't come on TV. For the last 10 years I am not appearing in any TV. But I started in 1995. The daredevil surgeon, Dr. Kumarveli, is just now mentioned. And thank you, sir, for honoring. I am also proud and honored to be here to present this oration as Professor C.K. Dhanasekaran Oration. Let's go to my topic. Look at the girl on the right-hand side and this. Both are different girls. Both are beautiful girls. Do you agree with me? The boys, do you agree with me? Both are beautiful girls. Okay? But there is some asymmetry. This girl, asymmetry, but she's happy. That girl, if you look at her eyes, she is not happy. So now we need to understand where exactly the problem, how we correct the deformity. The most beautiful woman in the world, Angelina Jolie. The middle picture is a normal picture. You can see the black mole on the right side. What I have done is cut it in the middle, transport, you know, that is the left side to the right side, and here the opposite. But the asymmetry phase is more pleasant, where this is more manly, that side is more feminine. You agree with me? So now there is a asymmetry which gives a pleasant feature also. Okay. Now let's come to my subject, where you look here. There is a asymmetry of the orbit. There is an orbital dystrophy, vertical orbital dystrophy of the time, whereas metropic stenosis, unicornal stenosis, plagicephalic, Along with that, there is a dystopia on the right side, and this side, there is a dystopia. Along with this, there is a asymmetry of the lower face also. And this boy, Professor, as Dr. Kumaraveli mentioned, TM joint ankylosis, leading to asymmetry. Vertical shortening. Everybody will say this side there is a flatness. He opens the mouth, the jaw deviates to the other side. Everybody will say on the right side is the problem. No, it is on the left side, vertical shortening causing the asymmetry. So I'm going to address the orbit, the midface, and the mandible, how create perfection. These are different other cases where you see sagittal stenosis, scaphocephaly. When there's a scaphocephaly, sagittal stenosis, there is every closer causing compression. The brain grows anterior or posterior. Looks like, can you see that the frontal bossing? And this boy, there is a, I'm coming to that. I will not go too much into embryology because that is not our subject. I will jump into the surgery directly. And another child with orbital dystopia, hypertelorism and orbital dystopia, first stage syndrome, TM ankylosis, and condylar hyperplasia. Now, as all our seniors said, you need to diagnose correctly, you need to plan correctly, whether you are doing the correct surgery or not. There were times ankylosis released, and they put some graft, genioplasty, it doesn't work. You need to have a proper technique to make it perfect. So, who creates all these deformities? Congenital. Congenital, acquired, and that is through trauma or tumors, and the brain is the one which sends signal and create. So you have the deformities of the forebrain, any genetic, any misinformation. If the information is not carried from the brain, you see the child, the features, the head is big, the trunk is small. So the brain forms first, so the brain sends signal. What we have studied early, the embryology, I'm not coming to that. Here, the fronto-orbito-nasal-lacrimal complex with the prosencephalon and the midbrain, the sphenoethmoid complex defect, and the hindbrain, the rhombencephalon, the pharyngeal arches. So here, this is a very simple diagram. This will stop with my embryology, prosencephalon, and rhombencephalon, and diencephalon. Here, the different color coding I have given, the yellow, the lavender, and the pink. This is a very important diagram. You must understand this. So what you see in the red is the first arch. That is so 8 rhombomeres, rhombencephalon, gives rise to 8 rhombomere. The first, second, and third gives rise to the first arch. You see the red color. Then the 4 and 5, the second arch, and 6 and 7, the third pharyngeal arch. Any defect in that creates all the deformities. Okay. Now I come to this. I said the brain predicts. Do I look like my father? Who predicts your face? Who predicts? A child is born, so the signals from the brain goes to the exterior. You say at the birth, so when the child, at the time of second month, the embryo, it is 180 degrees. The brain keeps sending signals, move forward, move forward. When you keep move forward, finally at the time of delivery, it is 71 degrees. And look at that. If there is any interruption, then you get hypotelorism and orbital dystopia, and it is too much moving forward, you get hypotelorism. Okay, let's go to the first star syndrome, hemifacial microsoma. Everybody knows about this, and you have the Brusarski's classification with Kamen's modification and all the clinical features of, due to the defect in the first brachial arch and disruption of the, as I said earlier, disrupted neural crest migration and vascular disruption, and characterized by unilateral hypoplasia of the mandible and progressive facial asymmetry. And this is the class, I'm sure most of your postgraduates, you all know about this classification, type 1, 2, 3. How do you diagnose? First is the patient history, photographic analysis, dental occlusion evaluation, and radiographic analysis, and soft tissue evaluation. And photographic evaluation, multiple views, you will be able to find out the defect where exactly. Because most of your patients, they come with the pictures, how they want. This is rule of 5 and rule of 3. Everybody knows. I think you all know the rule of 5 and rule of 3. That is the vertical proposition and horizontal proposition, and every how you classify, how you formulate. Next is deficient or excess. This is a good-looking girl, good-looking boy, but there is excess, there is deficiency. So zygoma to trigon, because you see that if this is 100, this 100%, this is 100%, the horizontal is 75%. Next, dental and occlusal. Most of the deformities, when there is a shortening of the ramus, you will definitely have a occlusal cant. So when it comes to the occlusal cant, you need your orthodontist help. If there is no orthodontist, you will not be able to do the orthodontic surgery. So this radiographic, the CT scan analysis will exactly tell you. You look at this straight view, there is vertical shortening. Because there is a vertical shortening, automatically the maxilla also deform, automatically the orbital dystrophy. I hope you understand. Okay? Though I know it's an oration, you can still ask me doubts. Look at this simple OPG. Yeah, OPG will tell you the length of the ramus. Unless you lengthen the bone equal to this, you will not be able to create the symmetry of the face. Okay? I hope you all agree with me. Next is 3D planning. That is virtual planning. Right now, nowadays, whether it is asymmetry or anything, or a cancer surgery, or you want to transfer a fibula, everything is really virtual planning control, which gives accuracy see my last sentence, accuracy is important. Next, mandibular asymmetry. Okay, hyperplasia. Hyperplasia, everybody knows condylar hyperplasia. There were times earlier, they do extraoral incision, they remove, and I'm going to show you what is happening in hyperplasia. See, all these clinical features, everybody knows. Let me go to the cases. Look at this guy. So, one of my very old case with a condylar hyperplasia. There is an occlusal cant. There is a downward swinging of the mandible on one side. Now, how are you going to correct? You look at the limbus on the angle of the mouth. There is vertical lengthening. So now, unless you do these were my early cases. So you do there were times we used to do model study, model, POP model, and a lift out one osteotomy to correct the cant. I have lifted. Okay, now there's a vertical open bite. Now do a BSSO and correct the open bite and lower body trimming with protecting the nerve. And that's how she is. Okay, another boy. In this boy, it is totally different. There is a condylar hyperplasia with masseter enlargement. Look at that. On the left side, you can see there is an asymmetry. So you need to do a lift out one, then BSSO, and part of the masseter I have removed. So it created a symmetry for him. Now let's go to all our seniors mentioned about TM joint ankylosis. TM joint ankylosis, a child comes to you, what is the algorithm? How do you treat? First thing, release the joint. Then costochondral graft. Wait for the child to grow, then correct the asymmetry. So here, what I have done is, I have published in 1996 in the International Journal of the Red Journal about how you transpose the temporalis muscle. You transform CC graft. Okay, I have done the CC graft. The graft started growing more. One side of you see, look at this graft. You see my CC graft, the CC graft started growing more. So creating more asymmetry. Again, I trimmed that and opened the mouth. And once it is trimmed, that is how she is. Okay. Now let's go to hemifacial microsomia. And where I already explained Kaben's modification to Sansky's type 1, normal condylar unit, but it is small. And type 2, A and B, the condyle is away from the glenoid fossa. And type 3, total disruption. So again, CC graft, mind you, in hemifacial microsomia, the CC graft doesn't grow well. It grows, but look at that, the post-operative, then later on, only way is either you augment with graft or distraction. So what I have done is, thanks to Ellis Rao, I'm not going into the latency period. So distraction and distracted, but she doesn't have, there is a microcia, she doesn't have 1 year, there is a defect in the soft tissue, she will require reconstruction. Now, how do we? One child I will show from, the child was brought to me long back when she was born. So what I have done is hemifacial microsomia, the macrostomia correction done. You can see this is a vermeil, and I already published vermeil and return flap. You won't get the star in the angle. When the child opens, it will look like a normal. So vermeil and return flap, the ear tags removed, that's how it is. The same child is grown. You look at that. So I have done the CC graft. Okay. Now there's a severe soft tissue defect. Now soft tissue defect again. My microvascular team, I have done the ALT, anterior lateral thigh flap. I remember one of the case from Saveetha. I think I saw William sir's picture also with the chief minister, where she had a Parry-Romberg syndrome. ALT was done, and this is the case where severe defect, anterior lateral thigh flap, with the microvascular anastomosis on the face, and that's all. Though I'm not able to achieve 100%. Now let's go to ankylosis. Ankylosis, we used to release the gap arthroplasty, release the joint, but still the girl opens the mouth with an abnormal opening. So where the defect is, look here, somebody tried to do some distraction, it failed. They came to me, and here you can see the gap arthroplasty is done, where unless you lengthen the vertical ramus, look here, this is the procedure, intraoral horizontal cut, and the distractor, KLS Martin's distractor fix, and from 66 millimeter, this is a video, short video to show you how you do this surgery. It's only half a second, half a minute. Sorry. This is the distractor. I'm placing and intraorally fixing the distractor. Intraorally, nothing extraoral, all intraoral. You have different type of screwdrivers available. The distractor is fixed. Lifort 1 osteotomy, simultaneous distraction, because there is a crucial can. So you do a Lifort 1, distraction, intermaxillary wiring, then you start distracting, the whole face turns. So you can see there the vertical lengthening with the IMF. Okay, the new bone is formed. So you see that, that's the situation. You see here, perfection is important. From there to here. So this is a case of TM joint ankylosis. Another case, look at that, absolutely no opening. So as Professor Kumaravelu said, I don't do under local anesthesia. Now we have all the latest techniques. We have bronchoscopic intubation. I have 7 types of bronchoscopy, pediatric, feet. So bronchoscopic, no tracheostomy. Then we do the same distraction. Mind you, that was ramus distraction. This is body distraction. Look at that. And that creates a symmetry. So assessment is important. For him, there's a vertical ramus is there. Vertical. So only the body was short. So once the body is decided, he is an ongoing case. Okay, this is another important case to tell you. The case from Singapore. The father called me. The child not able to breathe well. The teacher is shouting at him in the school. When he goes to the school, he's sleeping all the time in the school because he's not sleeping in the house. There is sleep apnea. He is snoring. So look at that. He's snoring. Yeah. So what I have done, TM joint ankylosis. First you have to release the joint, then do bilateral distraction. So first gap arthroplasty, temporalis interpositioning, otherwise the child will not do physiotherapy. After that, this is bronchoscopic intubation. You can see Dr. Ramesh doing the bronchoscopic intubation. This is not the same child, another child, where he is visualizing the epiglottis, visualizing the vocal cords, and visualizing the carina, and he intubates. You can see the vocal cords. So use the bronchoscope. Then look at that through the bronchoscope. He is pushing the tube inside into the carina, and then you can see again and see the length. So you don't need tracheostomy. You see that carina? You can see that. Okay. So sometimes for this child we could not do that. So tracheostomy, we got bilateral distraction for a child. Look at him. There's tracheostomy, there's a rise tube and bilateral distraction and distracted. You all know, I presume that you know about distraction, okay? So both the distractor removed. Now he's okay, eh? Immediately after the removal of the distraction, no snoring. Now before coming for the presentation, I called the father to send the picture. Look at him, he is happy. Now he doesn't sleep in the school. Okay? Okay, let's go. Look at this child. No TM joint ankylosis. The mandible, total body is small. This girl wants to get married. Now every boy is coming and looking at her. He says she is 30 years old. But they say, no, she looks too small. Now how to change the face? She requires vertical lengthening and body lengthening. Then only the face will look normal. So distraction of the vertical ramus, okay, and the body, that's how she is. Can you see the difference? Both vertical and the body, she looks normal. So whole change of the face. So this is another girl, ankylosis, where bilateral distraction. You can see the distraction. That's how she is. Before, after, right. Now this is again. See, I told you, you assess correctly. When this patient comes to you, somebody will try to do some genioplasty. That doesn't help. So you need to vertically lengthen. See, they have done, somebody has done the genioplasty. So you have to do the asymmetric correction by distraction at the clinic. Every day, 2 turns, 1 millimeter newborn forms. And you can see the newborn form. That's how she is. Okay? Do another. I just want to show you how much newborn has to form. Look at that. So much of newborn has to form. So there were times, there were 30 years back, our seniors were doing bone grafting. That never worked well. So same procedure, you can see here, after the distraction, this is the same patient, same 3D CT, and how newborn is formed. And that's how, this is another girl, very interesting hemifacial microsomia. You must see all this. This is a very confident came from Sri Lanka, where I have done the same procedure, but this was my very old case, so my result was not that good. Now I do a better job on microsphere. You get a very good result. I have changed my technique. So same, and there's a coloboma of the eye. I removed and reconstruct the eye, and the asymmetry correction. Okay, you look there, occlusal tan corrector from here to this. Now, one day she sent me the picture. You know, this girl went for a beauty competition and won the game. Can you believe? She doesn't have 1 year, asymmetry, going for a competition, so confident she is, you know, that's very important. This is a very interesting case from Nigeria. You know, somebody was operated, the mother called me, operated, put the external distractor, they went home. And 3 months they told to stay like this. 3 months asymmetry, then do the surgery. I told them, come back immediately. And I asked my orthodontist to see. I removed the distractor, and my orthodontist removed we put some brackets and put the elastics. And this is again floating bone concept of Hofmeister. Hofmeister is no more, he is from Berlin. He created. This is the ongoing case of mine where you can see here severe snoring, where look at that, very small mandible, where I have done the distraction of the mandible on the ramus and the body, both. You see here, single sitting, before, body distraction and ramus distraction, and creates a, look here, the newborn form, that's how he is. So asymmetry, you need to plan very correctly, and okay, this is a very interesting case. Okay, now he is also having severe sleep delay. He came from Sweden. Now, the point is, he told me, if I bring the maxilla forward and mandible forward, he is not happy. He says, I want to have the control by myself. How much to bring it forward? Because the girlfriend is not liking this face. He said, no, I want to change my face. So what I have done, same procedure, you know, advancement genioplasty, distraction of the maxilla, mandible on every direction. Look at how many distractors there. Maxilla two distractor, mandible two distractor, and vertical distraction. Can you see that? The same fellow. So nowadays the boys they have a mind. They want the jawline. They want to look like Arnold Schwarzenegger. Everybody wants to look like. See, so reducing the size is easy. The problem is making the size bigger is everywhere is a problem. So now this is the jawline which I created. He's happy. Now the problem is another important. Look at this girl. There is a asymmetry on either side, but this is not only caused by the mandible alone, but the soft tissue. So bilaterally, I have equal amount of masseter internal. You need, mind you, very difficult to remove. You need to be extremely careful because the facial nerve comes inside. Just if you break on the parotid masseteric fascia, then you will get the facial nerve. So you need to be very careful in this, using the diathermy to control the bleeding. Bilaterally, the masseter reduction, that's how she looks. Another girl, one side is bigger, one side is smaller, the masseter. So look, both sides I have removed different, they're very tricky, huh? Both you can reduce correctly. But muscle, if you remove, you need to, they come back to you for surgery. And this boy also same problem. Look at him, he has a double chin. And where requires advancement of the mandible, also removal of the fat. And that's how is another girl, same procedure. Okay. Now this is what I was mentioning about completely free of cost. Saveetha has done the surgery in medical college. I remember the case where this is, look at the subcutaneous loss of fat. It's the most very difficult to treat. Hemiphagia, you can treat. Team joint ankylus, you can treat. Parirhombox, the most difficult case where I used to take the fat from the abdomen, but mind you, young girls taking fat, you create the incision here, the mother-in-law will be very unhappy. Because they say, why such a big incision before marriage? So it's better to take it from the back, from the gluteal region, and subcutaneous fat tunneling, that's the asymmetry corrected. Now from the mandible, maxilla, now we go to the orbit, and the end of my lectures will be there. Look at this, there's a trauma. Very bad injury, somebody has operated, they have put skin graft. Actually, maxillofacial surgeons don't put skin graft. We try to use all the tissue available and we do our best to mark close. We are on the face, who will put the skin graft? So, multiple, see, look at that, the 3D scan, and fracture and malpost-cytoma. You need to refracture, multiple rib graft. Finally, that's how I was able to create a correction of the orbital dystopia. This boy, there's a tumor on the supraorbital region. Somebody removed and created orbital dystopia. Now, you have to redo the surgery, regrafting, and I already published, I'm sure you would have seen, white plate canthopexy. Please refer to my article, white plate canthopexy. There were times, olden days, I have seen CKD doing, if they do canthopexy means they go to the opposite side, transnasal wire they put. Because you go to the normal eye, sometimes you can go into the eyeball also. You all can go and so here, use the white plate, because the medial canthal ligament, it holds the eyeball as the tripartite attachment to the lamina propria of the ethmoid. So, white plate canthopexy, you go through my article, and that's how I have created. Correction. Now, this is an interesting case. This boy was on the sentry in Iraq. He was, the terrorists shot him. They shot him from the back. The bullet went from there, came through the face. Now, this was a very old case where that was the direction of the bullet. My textbook, you will see this case. And this was my earlier case. Nowadays, I don't do this procedure. I go transconjunctival, this was subciliary and elevated and correction of the orbital dystropia. Very happy. Another man, he had a tumor, benign tumor of the frontal lobe, the supraorbital region. Somebody has already operated. They did not remove the full tumor. You can see still part of the tumor is existing inside. So where the craniotomy with the help of the neurosurgeon and opened up, you can see the slides where completely the tumor removed and refixed. Now you can see after the removal and the canthopexy and the elevation of the eye. Now, this is very important, very, very important, where she is an anesthetist from Nair Medical School, Bombay. She is a transgender because nowadays, actually now we have stopped doing this surgery. Previously, now we started giving the testosterone. If a man wants to become a woman, what we do, but there were earlier cases, now we have restricted because their family life is important. Because this is a God's creation. Please understand, this is God's creation, a man's body, a woman's brain inside. Now, before coming here, okay, what you know the difference of skull, the different size, we have male and female skull, where you need to reduce the forehead, to create a man's face in the woman and reduce the, you need to reduce there's a frontal sinus, you should not disturb the lining, then put a mesh and the supraorbital region and rhinoplasty and genioplasty. She was in the car. I asked her the picture. She's driving, she sent me this picture. This is the latest picture. So from this situation, that's how. Okay, another case from New York is this girl, she wanted to again, problem is you need to correct the male baldness. Male baldness. You see that I'm getting bald slowly. Please understand, this is original. Huh? Nowadays, many. So the male baldness, you have to bring the scalp down. You remove this and bring the scalp down. So first point is to correct the male baldness and correct the supraorbital rim. Then masseter, angle, rhinoplasty, narrow, and the genioplasty. So you see here, I have removed the masseter and genioplasty, reduction genioplasty, forehead correction, and that's the result. Okay. Okay, this is from Singapore again, Malay girl, and same procedure, forehead reduction. And that's it. Okay. From this situation, I have created, this is the after surgery, and that's before she left. That's her boyfriend. The boyfriend is on the right side. Okay. Now, this is the latest picture. The same guy. The same guy. I don't want you to mistake me. This is the latest picture of her. Okay. Now we go to the final cases. So Cruzon syndrome. And the mother came to me from Sri Lanka. Doc, anywhere I take my child, everybody keep looking at her. Can you change the face to a normal face? Now this is a very important, where there's a mid-face deformity, you need to bring the mid-face forward so that the orbit goes inside. So it's a family of Cruzon. Everybody is Cruzon. So mother is hiding the face. Okay? But mother is not there. She is a beautiful woman. And where she already underwent craniostenosis and shunt. This you can see. I want you to see the video. Year-old girl with Cruzon syndrome. You can see the proptosis, the exophthalmos, the eyeball is up. The 3D CT shows the previous, so there is a communication. And now, after the government was internal distractor for the big fish record. So here, before the osteotomy and Kawamoto distractor, then you will know. Now, I can see mobilizing the facial distraction. Now, this is a Kawamoto distractor internal. There were times they were using RED, red distractor, that was too cumbersome. It will be on the face. The distractor fitted inside. So during the consolidation period, the child did not have use a hollow frame or the RED, checking it, how nicely it moves forward. You can see here I am using, see the mid-face moves forward. So this is quite painful for the child. Very painful for the child. This is a LIFO 3 osteotomy and a Kawamoto distractor fitted, bringing it forward. Look at that, how the maxilla totally comes forward. And that's how this is a new picture, the latest. She's grown. So completely, she doesn't look like Cruzon also. Okay, last case is this, the last but one, where unicoronal stenosis. Look at this child. You have the frontal closes. You have the sagittal suture, coronal suture, lambdoid suture, and the metropic suture. Now, when on one side the coronal suture is fused, you get the deformity like this. So where you need to do the calvarian reconstruction, take the frontal bundle and reconstruct it. This is another case. Somebody is already operated. They tried to do it. They were not able to. They were not successful. So they came to me late stage. Better to do it at the age of 6 months. When they come to 7 years, it's very tough. That's the planning, and we need to take a strip off from the temporal bone and modify it here. Planning. Take that part of the bone, modify it, and then fix it. I like to show you the slide where this part of the bone is brought forward. Look here, you see all the resorbable plates, and anteriorly I have put a rigid plate because otherwise the zygoma will not stand in position. So much I have brought it forward. So that's the situation you can see here. Post-operative, you see the orbit. So totally they changed completely. That's how she is. Okay. This is the post-operative picture. Another child. This is very important where you can see that metropic stenosis, where making the cut, bone cut, you need to take the bundle in your hand, then modify it, then refix it. Look at that. I'm taking the piece above the orbit in hand, then make small pieces, use resorbable because it's a 6 months old baby. 6 month old baby, you need to use the resorbable plate. The sonic weld, you all know the sonic weld. There's that's fixed and refix it on the face. You send a small amount of galvanic current, the screw melts and goes into the trabeculae and hold it. Okay? That's how he is. Fronto-orbital remodeling, the last case now. Here there is hypoteliorism and plagicephaly. Okay? Now how you need to correct both. So planning is important. You need plan with the CT scan. When the neurosurgeon does the craniotomy, take the bone and opposite it, turn it around, then you get a nice projection. That is how I planned it. You see here, and where you need to do the nasal accentration, remove the bone, bring them together. You want the procedure, I can speak about it. They do the craniotomy, then the frontal lobe is elevated up to the lesser wing of the sphenoid, then cribriform plate is identified, and don't stick the mucosa, otherwise they'll get anosmia. Then start cutting it, protecting the lacrimal duct and the optic stalk. So that's what it is. So this is referred by another government from Africa. So the health minister came to thank me. So that's how she is before and after. And this is the latest picture. And thank you very much. Beauty lies in the eyes of the beholder is an old saying. Beauty lies in the artistic hands of all of us. Thank you. Thank you, sir. Thank you.
So I think here is a standing ovation for sir.
Sir, thank you, sir. Thank you, sir.
Thank you.
Thank you, sir.
Thank you so much, sir.
Thank you, sir. Sir, thank you, sir. சார் இந்த அவார்டு தந்துட்டு போயிருங்க சார் வரலாம் சார் தேங்க்யூ சார் சார் வாங்க சார் தேங்க்யூ ஃபார் யுவர் டைம் சார்
Quite interesting.
தேங்க்யூ Thank you, sir. Sir, பாத்துறேங்க. Thank you, sir.
Thank you.
Thank you, sir. Sir, thank you.